All right, we are heading towards the final stages of our event, and I will invite the rest of our panel members, Dr. Thompson, Dr. Sonbol. We have Dr. Chauhan over here too, and Dr. Del Rivero, she's already here. So I have to make two more introductions. I think Dr. Kunz, Dr. Thompson, Dr. Sonbol have already been introduced. I'd like to introduce Dr. Jaydira Del Rivero. She's a medical oncologist and endocrinologist from National Cancer Institute at National Institute of Health in Bethesda, Maryland. Fun fact is Dr. Del Rivero's favorite artist is Vincent van Gogh, and her favorite painting by him is Cafe Terrace at night. Ooh. And then we have Dr. Chauhan. Please join us here I see Dr. Chauhan at the back of the hall over there. So Dr. Chauhan is a medical oncologist at University of Miami, and his fun fact is that he won various prizes for ikebana, which is a Japanese art of flower arrangement. Okay. Yep. That might be a second career opportunity for you, Dr. Chauhan. Okay, all right. So the purpose of this exercise is to just have some questions that are given to me by the patient, so we can go over all these questions. Our goal will be to get through all of these questions. I will state the question, and then we can just ask our experts about this. So the first question I have is the treatment with somatostatin analog, side effect, blood pressure. So we want to know which pathway does this occur, and what is the best class of antihypertensive medication that can be used to treat the blood pressure associated with somatostatin analog. So, Dr. Del Rivera, do you want?
I volunteered her.
Thank you. So the question is if the octreotide or lanreotide can cause high blood pressure.
Yes.
That's the question. And if that's the case, whether the hormones may have to do something with that. Okay. Well, depend on the hormones too. Dr. Kunz, and I'm sure you heard earlier, there is a very uncommon type of neuroendocrine tumor called pheochromocytoma or paraganglioma. So they tend to produce a hormone that raises the blood pressure. If there is no that evidence of tumors, then and you have a neuroendocrine tumor that is producing serotonin, like a small bowel neuroendocrine tumor that is producing serotonin, that can certainly cause symptoms like flushing, diarrhea. I'm sure you heard all of that. I don't think it's associated with blood pressure, to my knowledge. But that said, it's always need to keep in mind and discuss with your local provider just in case, there is something that can be done. Now, what I have seen, just a comment, is that sometimes, as we know, these neuroendocrine tumors can be in the abdomen and sometimes can be very close from the kidney. And the kidney has a vessel, and sometimes if that vessel is constricted because the tumor's nearby, that could potentially cause blood pressure, but not the sandostatin itself.
All right. I would agree. I think we all treat probably hundreds of patients with both the SSAs, lanreotide, sandostatin. Hypertension is by far not even the commonest, even the rarest complications. High sugars, cholesterol, definitely keep an eye on those. But hypertension, unlike certain other drugs like cabozantinib, VEGF, TKI, Sutent, which can cause high blood pressure, this is not, so unless it's a patient-specific, you're allergic to a drug, and that's why your body is reacting. So there's a very patient-specific concern, then you please address it with your oncologist, but it's not a concern with somatostatin analogs.
All right. Thank you very much, Dr. Del Rivero and Dr. Chauhan. We're going to be moving a little bit faster because we have a bunch of questions over here. So the next question is, can lutetium dotatate be used more than once if the first treatment failed? How can we find out the trial study worked across the board? So we have the NetRetreat study. Dr. Chauhan is the principal investigator of the national principal investigator of the study. I can answer part of this question that we're in the process of opening this clinical trial here at University of Arizona Cancer Center. We're almost there, so stay tuned. I promise you next couple of months we'll have the trial up and running. But Dr. Chauhan, do you want to say something about this too?
A quick comment. So yes, retreatment strategies with PRRT, be it Lutathera or some other radiopharmaceutical, be it alpha, is possible. In fact, there are at least 14 studies from Europe which has showed that it's not only safe but effective when re-challenged in the right patient. So what is the right patient? The patient should have benefited at the first go. So if you tried the Lutathera and it didn't help you, then you clearly are not a good candidate. But majority of patients will have some degree of benefit. In my mind, we consider at least 1 year of benefit, right? But these definitions are fluid. So yes, retreatment strategies are good. The problem is there's no FDA-approved retreatment strategy. So I highly encourage patients to consider one of the 2 studies which are going on in the US right now, the NET retreat study, which is lutetium once as a dotatate retreatment at progression, or Action 1 study, which is an alpha emitter study. And they're available at several centers. I'm glad. Thank you so much, Dr. Arshad, for opening NET retreat study.
Absolutely. So thank you for Dr. Chan for answering this question. Next question is, can non-functional tumors turn into functional tumors? And if the second question, if there is no evidence of disease on the CT scan, does it mean that are there any symptoms that are indicative of new tumors? Dr. Sonbol, do you want to answer this question for us?
Yeah, sure. So can non-functional become functional? I mean, it's unlikely, and in practice, it's not something that we typically see. But sometimes maybe, like if you're getting, for example, if we're talking lab work, you might get like 5-HIA, which is the serotonin product. You might have it like mildly elevated, but whether that's clinically really relevant or not, it's unclear. But in general, I would say no. So non-functional does not typically go functional. Of course, there are always exceptions. Now, for the second part about the CT and
if there is no radiologic evidence, if there is nothing on the CT scan, can symptoms indicate disease progression? If symptoms,
yeah, and I think all of us we see these referrals where the patients they have symptoms and now the tumor is out, and unfortunately they still have residual symptoms. I think at that time it's very unlikely that the disease is what's driving the symptoms. I would add here that before declaring that this is not the tumor causing this, kind of talking about imaging, of course, we want to make sure that we've done all the necessary imaging. So CT, of course, is not enough. We have to do the, dotatate or FDG, depending on the type of the tumor. And then when we exclude that, with a PET dotatate or the appropriate imaging, then if the patient still has symptoms, then we have to work up these symptoms, and probably it's not related to the cancer. It's unlikely that the cancer is what's causing this.
thank you very much, Dr. Sonbol. Oh, okay, sure, absolutely.
So I just want to make a comment about oh, I'm sorry.
What? Does it? Yeah, just.
Can you hear me? Okay, great, thank you. Just a comment about functional tumor that is non-functional and becoming functional. So very rarely happen, but it can't, is that, for example, in pancreas, neuroendocrine tumors, over time, they can secrete hormones. Most of the time is a hormone that produces excess of cortisol. We call that what we call paraneoplastic syndrome. It also happens with other cancer types like lung cancer. It can also happen that depending on it, over time, they can produce hormones. Rarely happened, but it can't. And these other hormones that are not necessarily associated with the hormones that are located in the pancreas.
Can I also add one comment? That I completely agree. You can see how excited we are about NETs, right? So another scenario that we have to be aware of, when patients sometimes present initially and may have a low volume disease, it's not enough to secrete enough serotonin or have symptomatic disease. But at progression, especially if they develop liver mets or ovarian drop meds, because ovarian venous supply bypasses liver and then you get systemic exposure to serotonin. In those situations, you might have started your journey as a non-functional or asymptomatic patient, but then all of a sudden, a few years later, you started having flushing and diarrhea. So it's really the tumor didn't change. It's just now manifesting because of the burden of disease and infestation liver. So that is a very unique nuance that needs to be factored in.
All right, that was a very comprehensive answer to this question. Oh, let's keep moving. Are treatments different for functional and non-functional tumors? Does chemo work for functional tumors like leukogonoma or any other types? We'll have this question for Dr. Kunz. She ran the trial with chemotherapy. I think she'll be a good person to answer this question.
Thanks, Dr. Arshad. So does the treatment differ for functional and non-functional? There are some nuances. I would say for patients with functional tumors, we have to worry about controlling both the symptoms of hormone excess and the tumor growth. Often we'll start with a somatostatin analog like octreotide or lanreotide. It can do both. But if the tumor is growing, we then will often maintain the somatostatin analog for hormone control and add something to that for tumor control. There's some additional nuances. For example, we often will really need tumor shrinkage for patients who have functional NETs, because if you can make the tumor burden or size of the tumor spots smaller, that often means that there will be less hormones secreted, and there are only certain treatments that yield shrinkage compared to others. So chemotherapy can sometimes do that. Liver-directed treatments can sometimes shrink tumors. So those, I would say, are the primary nuances.
Okay. Moving on. So our dotatate PET CT is being done locally here in Tucson. And is the scan necessary before beginning the PRRT treatment? I think Dr. Thompson, you're next.
Yeah, you bet. Yes, fortunately, we actually have dotatate PET CT readily available to us. We even have a new digital PET CT that has fabulous crystal clear images. So yes, the dotatate PET is readily available here in Tucson. And yes, we if we don't see it, we don't treat it. So in terms of qualifying for the lutetium-177 therapy, the tumor cells would need to overexpress that somatostatin receptor that we would see on the dotatate PET CT.
Yes, thank you. One of the next questions is one somatostatin analog better than the other? Octreotide or lanreotide? So.
I've heard someone say it's like Pepsi and Coke.
Yeah. I think that is the best answer. This does not require any further explanation. Okay, so I think this is a question related to the personal care. If my tumors grow despite somatostatin analog, should I stay on the somatostatin analog? All right, so Dr. Sonbol, do you want to take this one?
If the tumor grew on the somatostatin, should I stay on the? I think the exception. There are some exceptions. Like typically, I look at somatostatin analog as two functions. One function is really anti-tumor, so we're given it to stop the tumor from growing, stop it from spreading. And then the other thing that I want the somatostatin analog to do is to stop the function of the tumor. So if the tumor is producing hormones, I want to stop that. So if it failed with the first function, which is to kind of suppress the tumor and stop it from growing, it's still there available for the second thing. So long answer to say that for functional neuroendocrine tumor, I actually ask the patient and tell them, you know, when you skip doses, like let's say I have a patient, they have functional neuroendocrine tumor and now they're getting another therapy, and while they're getting, let's say it's cabozantinib, and I ask them, when you skipped the somatostatin analog at some point, did you really suffer from that, the skipping? If they say yes, that the somatostatin analog actually helped me symptomatically, then I continue. So I tend to continue in the functional neuroendocrine tumor, especially also there's a question about what to do after PRRT. You do the 4 doses of Lutathera. Should we continue or not? That's a question it's a big question mark currently, whether we should continue or not. But I tend, and many others, I think probably on the panel, would agree to continue for the functional neuroendocrine tumor patients because we want that benefit.
All right. Thank you very much, Dr. Sonbol. The next question is specifically for Dr. Del Rivero. Do somatostatin analogs cause high blood sugar, and what can we do about it?
Yes, it can. And as Dr. Chauhan mentioned earlier, that's one of the side effects of somatostatin or lanreotide or octreotide. Very small percentage, about 4%, may cause hypoglycemia, so meaning low blood glucose, but that's also rare. The reason why I'm saying that is because sometimes we need to be a little bit more cautious in patients that have a type of neuroendocrine tumors that is producing insulin, and this insulin tends to lower the blood glucose. But overall, yes, it can cause hyperglycemia, and in those situations, that's always said that an endocrinologist will need to be involved so that we can help manage the diabetes. Of course, if we see that the blood glucose, once you start somatostatin agonist, if we see that blood glucose is getting higher, then we need to measure what we call a hemoglobin A1C. So the hemoglobin A1C tells you your glucose levels within a 3-month period. And depending on what the numbers are, so the endocrinologist can determine when to start either a pill or any other medication. Now, just a question, and I don't know how you feel about it, is about Ozempic. Because Ozempic has been also used to lose weight, has been also used to also for diabetes, and the initial indication was for diabetes. Initially, in the beginning, I don't think I was saying it's okay, but now more and more studies we're seeing that actually, based on the mechanism of action, at least in the lab, it can make the neuroendocrine tumor worse. So now I don't know how you feel about that, but again, this is very early. We still don't know that information. We still don't know what is going to be in humans because we don't know. But if that's the case, I don't know how Dr. Kunz feel about that.
Yeah, I get asked this question all the time. I think I guess it's very early days, and so I think we just don't know.
Don't know. Exactly.
Maybe to rewind a little bit, there is a warning for medications like Ozempic and Wegovy to not use it for patients with something called medullary thyroid cancer, which is sort of a relative of neuroendocrine tumors. So that's a definite contraindication. I will say I have a slight difference of opinion only in that, we just don't know. So I am allowing my patients on it. There are a lot of other, really great health benefits. So I think until we study that prospectively in patients with NETs, we just don't know.
Thank you, Dr. Kunz and Dr. Del Rivero. Next question is related to PRRT. When should I be worried about low platelets? How low is too low? And what can we do about it? So, Dr. Thompson, do you want to tackle this one?
Yeah, sure.
So I think the question is a good one in that it's important that we follow your blood counts, not just the platelets, but your red blood cells, your hemoglobin, your creatinine, your liver function tests, your kidney tests. These are all would be followed routinely with our medical oncology colleagues. In regards to the platelets, the initial, I think the requirements to be above 75, we have criteria that we can follow in terms of toxicities. And depending on where the platelets, not just the platelets, but hemoglobin, or you take your pick where it falls, we do have the option of a couple things. One is we can delay the therapy, delay the next cycle. So we could push it back to allow the body to potentially recover. And then another option is potentially to reduce the dose. So typically at this moment in time, patients get what we call 200 millicuries of lutetium-177. We're able to reduce the dose, let's say, to about half that to help alleviate or potentially avoid toxicities that may occur as a result of the lutetium-177 on the bone marrow.
Thank you very much, Dr. Thompson. Sure.
Yeah, just a quick comment. I totally agree with Dr. Thompson, but I just want to also comment on something after finishing the lutetium. I think it has been shown in multiple studies, and we see it in practice, that it takes up to 6 months almost to really fully recover from the lutetium-177. And after 6 months, if you still have thrombocytopenia, meaning low platelets, I think those patients should get a bone marrow biopsy to really evaluate that bone marrow, because there are some things in the bone marrow that can happen that they are precancerous, so not necessarily cancerous, but they can predispose the patient and increase the risk for future bone marrow cancer. So I think it's very important to recognize that as one of the things to look at.
We can move on to the next question, and Lisa can grab that write-up material to follow up on that question. So, can patches of red flaking, peeling skin on the face and legs be a result of lanreotide injections? Dr. Chauhan, do you want to handle that one?
Again, fortunately, not a common side effects of somatostatin analog. We use other chemo and TKIs where hand-foot syndrome or skin dermatitis can be seen. In Afinitor, it can be seen. Kip-TEM and cabozantinib has been seen. With SSAs, this type of reaction is fortunately not common, but could be very patient-specific. One of the things that, is the skin reaction. If patient has glucogonoma, I have seen some, maculopapular or erythematous rashes in that. That's not my experience with SSAs. I wonder if there's an underlying dermatological condition or just a specific reaction to this drug. Now, we answered the question that both are same, tomato, the two drugs. But whenever there is a weird reaction, I often try to switch the drug and see maybe some component in that particular product that you're reacting to. And sometimes patients tolerate one drug better than others. So this might be something that you can consider.
Okay. Thank you very much, Dr. Chauhan. This next question is related to PET scan. Is there a time frame to wait between the PET scans? Can it affect the accuracy? So, for example, the first PET scan was done 2 months prior to hemicolectomy surgery, which showed primary lesion in colon that has metastasized to lymph nodes. And then the second PET was done 2 months after surgery that showed no signs of disease. So there's an interval of 4 months in between. So they're just trying to ask, is there any difference in changing the interval between the two imaging?
So I believe the question is the timing maybe post-surgery? In regards to the interval of 2 months after the surgery, that would be most appropriate, or even longer. And the reason is that the sugar study, the FDG, the metabolism study, can be very nonspecific in that it can detect inflammation from a recent surgery. So to wait at least 2 months, as in this example, would be most appropriate. Now, in terms of following up, you wouldn't necessarily need to do, every 2 month PET CTs. I think there's certainly other imaging modalities or clinical presentation that would dictate then your long-term follow-up, depending on the clinical presentation, depending on the pathology, depending on the extent of disease. So, but to repeat a PET scan after surgery debulking to ensure that there's no new disease, and to wait that 2 month time interval would be appropriate.
Thank you. I think the next question is, an excellent, does anyone have an excellent substitute for crayons?
There is the other brand is Zempep, but unfortunately, both of them are very expensive. I want to mention that Zempep for quite some time, I think it's still ongoing. They do have patient assistance program with Nestle. Yeah, so you can discuss that with your care team if that's an issue. I mean, I've had patients driving from Phoenix to Mexico to really buy crayons. It's really a frustrating thing because a lot of patients need the crayons and the pancreatic enzymes, but we still don't have. There are over the counter and there are some on Amazon that my nurse told me about. It worked for few patients, but for the majority of the patients, it just doesn't have enough dosage of enzymes there.
Yeah, I'm not aware of any other substitutes either. I mean, I think the question was also that is it an excellent substitute? I don't think that there's anything that works better than that. It's definitely in care gap, and that's definitely something that we can, look into active ongoing research that can certainly help our patients. Next question, is there neuroendocrine tumor patients that have been cured of the disease? And then the second question is related, what is any research that is being done with DNA using artificial intelligence related to neuroendocrine tumors? So I will not pick on anyone for this, but I will just expect volunteers.
Well, I'll take the first one. Any patient cured? Yes, I mean, definitely. You heard the talk about surgery. I think surgery is definitely one of the curable options for patients with neuroendocrine tumors when it's localized. That's when we aim, like, let's say it's pancreatic neuroendocrine tumor or small bowel. We do the PET dotatate, and if there is no evidence of metastatic disease, then technically the surgery intention is cure. After surgery, we usually follow for up to 10 years at least. So this is different from other cancer. You hear breast cancer, 5 years I'm cured. It's actually, we follow for 10 years. And after 10 years, most of the times we say, okay, well, everything looks good. We declare the victory. We congratulate the patient. It is possible.
I'll try to answer the AI question, but I'll answer it in a slightly different way. AI is definitely transforming medicine. That's for sure. I'm using an AI tool to help me take notes in clinic. I don't know if you guys are doing that. We are using AI clinical trial patient matching tools that help us match patients that I'm seeing in clinic with what trials we have available. So AI is being used to help interpret imaging. So I think that it will get there, but we're already seeing it used in very practical ways. So stay tuned.
Okay, so thank you very much. The next question is there any ongoing research to detect and identify original cause of neuroendocrine tumors besides just having bad luck? And the second question is related to CAR-T, which Dr. Kunz briefly touched in her presentation. So
I think Dr. Del Rivero between us is doing a lot of molecular studies. She actually leads a national study called Natural History Study, trying to understand the molecular underpinning of why tumors happen and how they evolve. But and I'll kind of cede to her to explain more about the causative. So there is a small pocket of patients where it happens as a part of mutations, the germline mutations, and we had a beautiful, not in this maybe, I guess, but we had a talk about familial neuroendocrine syndromes. So that is one of the piece of the puzzle. About 10% midguts, up to 20% or 19% pancreatic that's develop as a part of some sort of germline mutation. And it's still evolving science. We're learning more about it. But vast majority, it happens as a CHAS mutation. One of the, and unfortunately, that's true for most cancer, actually. Outside 3 or 4 or 5 cancers, like smoking and lung cancers, hepatitis C virus and liver cancer, alcohol, maybe. The causative etiology for majority of cancers, we don't know why it happens. It's a random CHAS mutations. As our cells divide, they incur mutations. Our surveillance system is usually able to pick up most of these faulty cancer cells and wipes it off. But when it misses that, or the mutation makes them immune to our immune system and they survive, that's when the cancer happens. That's a basic overarching principle. So unfortunately, I don't think there's something in the diet or something in the environment that we can put our foot on and say for sure this is why. And you know, if you look at the global neuroendocrine tumor incidence pattern, incidence of neuroendocrine tumor is on the rise, not just in the West, but in the East, in everywhere, Middle East as well. Some different cultural, different food practices, etc. So I think it's just we're getting better at diagnosing it. We don't really know if this environment has a role in it, but it's something that we should study, and hopefully we'll have an answer. Dr. Del Rivero, have you figured out something?
It's okay. I'm on the spot here. So yes, as Dr. Han mentioned, we do have a study. It's called a natural history study and biospecimen collection, where we obtained tissues and blood from the patients, and we do an extensive molecular profiling. The idea is to be able to determine, what makes neuroendocrine tumors. We're also looking at what we call epigenetic changes, or changes and mutations over time. But we still don't know the answer. Part of the study, we collect a family history, and also we collect any information, exposure to toxins, just to see whether there is any commonality among that information that help us understand a little bit better about, where this may coming from. But as of now, we don't have an answer.
Okay. Stay tuned.
Targeted therapy pills. What is the duration? Several months or forever? Dr. Kunz?
Yes.
I presume this means some of our targeted therapies like cabozantinib or sunitinib or everolimus. Would you interpret it that way? So these are, I would say, to back up a little bit, a general principle in oncology is that we will use a cancer or a treatment that is directed at slowing down tumor growth as long as a patient is tolerating it and as long as it's working. So I think that we would use these daily pills, get scans, determine if the treatment is in fact working or a patient's tolerating it, and if there was evidence of progression or new growth or evidence that a patient wasn't tolerating it, I would stop it, set aside, and move to something different. So those targeted therapies, though they may work a little bit differently, the general principles for how we think about treatment really apply broadly.
Thank you, Dr. Kunz. We have 3 questions left. One of them is specifically for Dr. Kunz. I'll save it for the last. The next question is carcinoid heart disease is a devastating complication of carcinoid syndrome, and 5-hydroxyindole acetic acid, which is 5-HIAA, is a good test to monitor. But why can't this test be done to follow this, considering that the tumors change? And even non-functioning tumors, if there is significant liver tumor burden, it's a threat. So does anyone want to handle this question?
I can start, and maybe the rest can add. Yeah, I mean, it's an underdiagnosed disease for sure. I think we have to look for it more. Any patient who comes into me with it's carcinoid disease, you can so any patient who comes in, we do plasma 5-HIA to kind of assess whether the tumor is functional or not. The other way of doing it is to look at the 24-hour urine collection. Now, if the patient has a functional neuroendocrine tumor, then we typically do an echocardiogram every 1 to 2 years, and really some cardiologists even recommend yearly. Now, proBNP is another test that's usually done as a screening test, and it is on the cardio-oncology guidelines to kind of suggest doing it. However, the challenge with it, another financial challenge, is that a lot of times we don't have we don't have it covered by insurance. I know there has been some work with Lisa and others trying to kind of come up with a billing code that can make it happen. I don't know if Lisa, do you have any? No, okay, yeah, not yet. So hopefully in the future we'll have it covered. But yeah, it's very important to recognize it, and then when it is recognized, we talked how it can affect the serotonin can affect the right heart valves, the tricuspid and pulmonary, as we discussed in the talk. But when it's recognized, I think it's very, very important to go to a net center where they have a surgeon and a cardiologist who is familiar with carcinoid heart disease. I think this is very, very important and key in this.
Okay, so the next question is, I think, about uncontrolled hot flashes that I don't have. It starts with, I don't have hot flashes. I spoke too soon. I have thermonuclear blasts multiple times each night, go from 0 to 5 million degrees in 2.3 seconds. I get soaked from head to foot. My heart races. It's debilitating. It really impacts my sleep, which then impacts the next day. Help needed. Can anything be done about this?
The question is around sort of hot flashes, but associated really with like sweats. Maybe I'll make a comment and let you think about it as the endocrinologist on the panel. Typically, carcinoid syndrome flushing is dry and not associated with sweating. So that would make me wonder if there was something else happening. And this is a very common scenario, and that's where there's overlapping vague symptoms that may actually overlap with other more common conditions like menopausal hot flashes, et cetera. But to our endocrinologist here, I'll pass to you.
Yes, that's correct. That's absolutely agree with Dr. Kunz. And that's one where you have these specific hot flashes that happen at night. I think there may be other causes that you need to look at. And that would be, as Dr. Kunz said, depending on the age, menopause. Sometimes, and in those situations, and I don't know if you have any experience on that when that happened, and we sometimes use SSRI because that can help a lot with the hot flashes. So there is a medication called sertraline, and there is another medication called venlafaxine. I think one is Effexor. So these medications are used as antidepressants, but they also has been studied that can also help with the hot flashes related to menopause. So in those situations, in a female that has these hot flashes that may not be related to the neuroendocrine tumor and possibility of that could be because of menopause, I think this medication can be very helpful. And the other question is because these are serotonin reuptake inhibitors, could that make the neuroendocrine tumor worse? And it's not. So there is no data of that.
Thank you very much, Dr. Rivero. I think the last question was primarily for Dr. Singh. There were a bunch of questions related to liver resection. Dr. Singh unfortunately had to leave. We don't have anyone who can answer these questions, but there's on the side note, there's a little question for Dr. Kunz. Seems like it's more of a political question. It just says, has Dodge really hurt neuroendocrine tumor trials? I saved this one for the last.
No comment. Without being political, I think I made a comment earlier that we certainly get funding from the federal government to do important science and to do clinical trials, to ask questions around basic and translational science. And I am worried about science. I'll be honest, I'm worried about scientific misinformation, and I'm worried about the conduct of science. I think we're only going to see what happens in the coming months to years. I think most of us here are committed to doing the science in some way. It all needs to get done. So maybe I will stop there.
Thank you very much, Dr. Kunz. That was a very good and a very balanced answer. And before we sign off, I'll just ask a question to our panels. What is the treatment you are most excited about for neuroendocrine tumor? So please volunteer. Please feel free to say the comments you have.
I could start. So for high-grade neuroendocrine carcinomas, I think there's a lot of exciting drug development. Finally, after several decades, DLL3 targeting with T-cell engagers, DLL3 targeting with CAR-Ts, radiopharmaceuticals, is going to be very, very exciting in next several months to few years to come. For low-grade NETs, I'm very excited to see the next generation of PRRT studies. So PRRT has been such a game changer, a pivotal moment in management of neuroendocrine tumor patients. The next set of studies, be it alpha PRRT or combination studies with standard PRT plus something that is making PRT work better is very promising, and a lot of really cool data that will come out in next several months to a year or so. So stay tuned.
Comments?
I think what I'm excited is because we are now having more and more data on different targets within the neuroendocrine tumors that may not necessarily include PRRT. So more of we call this an antibody drug conjugates or antibodies against the receptor, the somatostatin receptor. I think those are upcoming. Still, a lot of them is in the lab, but based on presentations, it seems quite promising. So we're really excited to see when it's to see in humans and how it works. My side is more about developing other therapies that aren't necessarily PRT. So we have in my institution an antibody drug conjugated that targets another. It's not the L3, it's the LK1, but it's within the same family. Yes. And we'll see how those first in humans. So we're still trying to find what is the maximum dose that the patient can tolerate. But it's a good target, in my opinion, and we'll see what the results are. So this is what I'm excited about, other treatment options with different targets that are not necessarily PRT.
They took all my answers. So hopefully you can see there's just been so many advances in the space. I guess two things I'm hopeful for and excited about. One is that our clinical trials have moved from studying kind of new drug versus placebo or new drug versus octreotide to comparing one drug against another. I think that's a really important pivot in our field. And then I'm really excited for us to be thinking about quality of life and incorporating that into clinical trials. I think that, as many of you know, the well-differentiated low-grade NETs are really more of a chronic cancer, and I think it's critical that we think about survivorship issues kind of in the front of what we're doing.
I agree with all the above. Yeah. I mean, all the things that were discussed really are exciting. I think one thing I'm excited about is that now we're kind of in the journey of understanding neuroendocrine tumors much more than before. We still have lots of things to kind of learn about, while that's why we're doing all the research. But for example, one of the things that I'm excited about is the tools that we can utilize to optimize the treatments that we already have. So, for example, when to use PRRT. Is this patient gonna respond to PRRT or not? So these are tools there are some kind of new data that's promising. Hopefully we will have those things maybe in the near future in the clinic to kind of tell us which patient will get what therapy. So you see the patient in the clinic, you do these testing, and you tell the patient, okay, you're probably gonna have benefit from this treatment, that you're not gonna benefit from that treatment, and things like that. That's what I'm excited about.
So I'll just kind of echo what has already been said. And in regards to the PRRT, I'm definitely excited to see what comes out of the alpha therapies and the combination therapies. In the prostate world, we do a lot of combination therapies, and I feel like neuroendocrine tumors is starting to kind of head in that direction. I would say I'm very excited about the opportunity here at University of Arizona, where we're really focusing on dosimetry. Right now, patients get one size fits all, sort of in terms of the 200 millicuries. But who's to say that we have software tools available to us, like Dr. Sonbol said, where we can actually do imaging studies and draw regions of interest around each individual tumor and say, hey, how much is required to actually kill this tumor? How much is this tumor getting? Do we need to give more of a dose, less of a dose? Which may then help us have sort of expand the current use of the therapy we already have. Who's to say that 4 is it? Who's to say that it needs to be every 2 weeks? And I think there's so many questions that we can answer to better optimize the tools that we have. And we have a lot to look forward to in our future.
Okay, thank you, Dr. Thompson. It's only fair I answer this question too, since I asked one. So everybody on the panel stole my answer. So I'm the last one to go. So absolutely excited for all the things that are mentioned. I'll add just one thing, that I'm really excited that the notion that the neuroendocrine tumors may be, they're not rare. They may be uncommon, but they're not rare. That has started to really spread across the country, not just the country, across the world. And I think this is a very exciting time in the field, that people have started to realize that these tumors, they definitely require attention not just from the providers, but from the leaders, from clinical trials, from research, from our community members. So like I always say, we may be late to this race, but the race isn't over. It's not a sprint, it's a marathon. We just started, we'll keep going. Thank you very much. I will, let Lisa give the closing remarks, but I just want to say thank you to everybody for making this a huge success, for coming, a huge gratitude from me to our clinical experts, researchers for sharing their insights and dedication, our organizers, Neuroendocrine Cancer Foundation, who have put the hard work to put this together, and of course, most important of our patients. This is why we do what we do. I will end this with this beautiful quote from Dr. William Osler, that a good physician treats the disease, and a great physician treats the patient who has the disease. So let's carry this spirit forward, and in our work, ensuring that science and compassion go hand in hand together. Thank you very much.
Let's just give an extra hand to Dr. Arshad, who hosted this event and the provider events that was going on next door. All of the work and commitment from Dr. Arshad and his team here at Arizona Cancer Center has been amazing, and we just could not be more grateful. So let's really give him a round of applause. Yes. We also want to thank all of our speakers, and Dr. Aman, Chauhan, Dr. Jaydira, Rivero came in and pitched in, because some of our speakers had to leave, and they joined us from next door. So thank you so much. They wanted to join our party because we were having so much fun. And thank you to all the supporters, of course, because we would not be able to do it without the support of the supporters who provide the food and all of the things to make this happen, so it can be free of charge for all of you. So we invite you to join us downstairs. We have a lot of food and time to hang out and mingle. We will not kick you out a certain time, and we just invite you to just connect, as we talked about, connect with each other, and ask your questions, and make something deep and meaningful connection. So thank you all for being here. Thank you today.